With clinical consultation on organ failure following surgery, prophylaxis, and treatment by 5 distinguished surgeons from 6 noted medical schools, this is Audio Digest Surgery, Volume 17, Number 7, for the week of April 15th, 1970. The surgeons you'll be hearing: Daniel W. Elliott of the University of Pittsburgh School of Medicine, Frank L. A. Gerbode of the University of San Francisco School of Medicine and Stanford University School of Medicine, David M. Hume of the Medical College of Virginia, Angus D. McLaughlin of the University of Western Ontario Faculty of Medicine, Samuel R. Powers, Jr. of the Albany Medical College of Union University. Liver failure that occurs in the post-operative period usually occurs in patients who have some liver problem pre-operatively. Let's listen as our first speaker, David M. Hume, discusses some standard methods of treating hepatic failure.
Now, when hepatic failure occurs, whether or not the patient goes into coma depends on a variety of factors which vary from patient to patient, but some of these factors, in the presence of alkalosis, hepatic coma is much more apt to occur because whatever the metabolites are, in addition to ammonia, which pile up in the blood in hepatic coma, these metabolites can find easier access to the brain cell in the presence of alkalosis than in the presence of acidosis. And it's been well known that you can put a patient into coma who's on the borderline of coma by making the blood alkalotic and bring him back out again by making the blood acidotic without doing anything else to him, and you can do this repeatedly. Hypokalemia is also a contributing factor, partly because it contributes to alkalosis, and both of these things should be fixed when they're present in hepatic failure. Blood in the GI tract provides a ready source for the absorption of toxic products in patients with hepatic failure, and of course you all know that if one gets the blood out of the GI tract, one can sometimes bring patients out of coma because you stop the absorption of these toxic products. This is certainly true as far as ammonia is concerned, although this is by no means the only toxic product which leads to hepatic coma, or perhaps not even the most important one. Nonetheless, if one can cut down on the absorption of ammonia by giving neomycin, which destroys the organisms that split the blood down into ammonia and some of the other byproducts, one can sometimes bring patients out of hepatic coma by this method. Now, some of the complicating factors: bleeding varices are present, or if there's blood in the GI tract from a bleeding ulcer or any other source of blood in the GI tract. This, of course, contributes significantly to hepatic coma, and one has to take steps to stop the bleeding. The presence of ascites may complicate coma in 2 ways. First of all, it may raise the diaphragm, it may make breathing more difficult, may interfere with the respiratory tree, and secondly, it may lead to the third complication, which is the hepatorenal syndrome, to which ascites contributes in some peculiar way. This is a complicating factor because if one is dealing with both hepatic and renal failure, one may have to dialyze the patient. This may mean giving him heparin. It may contribute again to his bleeding and therefore complicate the entire cycle. Hepatitis, of course, is a significant complicating factor because in any patient with hepatic coma, whether or not he ultimately comes out of coma depends on whether or not his liver is able to regenerate some cells, whether it's able to recover from whatever it was that was injuring it. And if he has a superimposed hepatitis, particularly if it's a severe acute fulminating hepatitis, the likelihood of his liver cells being able to recover is very much less. Now, these are the general principles in the treatment of hepatic coma from whatever source. First of all, one wants to reduce the production of the substances causing coma. And of course, this means stopping bleeding because this is a source of substances that produce coma. One wants to reduce the blood levels of toxins. One can do this by exchanging the blood with blood that doesn't have toxins in it, thereby washing it out, or one can do it by cross-circulation or several other methods of treatment. One wants to reduce the tendency for the toxic substances to enter into the brain cell, and this means correcting the alkalosis. One wants to be able to buy time so that if the liver has the capacity to recover, it's able to do so. And one wants to reduce the effect of the toxins on the liver. I think one of the things that has been interesting to us is that these things that pile up in the blood in the presence of liver failure do at least 3 things. They affect the function of the kidney and lead to the hepatorenal syndrome, which is not a pathological change in the kidney, it's a physiological change. They interfere with cardiac action and produce shock, and they interfere with the function of the liver cell itself, so that if you can correct the hepatic coma by getting the blood free of these substances, the liver itself has a better chance to recover, as do the heart and the kidney. And one wants to improve circulation because shock and hypotension further injure the liver, which responds poorly to the presence of shock, particularly when it's being injured by some other substance. Now, this is the sort of standard treatment of hepatic coma. The alkalosis and the hypokalemia are treated by giving potassium chloride intravenously. I think this is a key aspect of the treatment of coma, particularly since many patients in coma with hepatic failure have been given diuretics for their ascites and have often lost a great deal of potassium and sometimes have a significant degree of hypokalemia. One can give CO2 to breathe, which will also produce a measure of acidosis and help to correct the alkalosis. And if the acidosis is very severe and can't be corrected by any of the simple methods, then one can dialyze the patient, and peritoneal dialysis is a simple way of doing this. I hasten to add that in our opinion, dialysis doesn't do anything else for the treatment of hepatic coma. It doesn't get out any of the damaging agents from the blood, and we've had experience with dialysis that dates back to 1950 for hepatic coma. But it does correct the alkalosis, and one can do this quite easily by dialysis. If there's blood in the GI tract, the two key things are to give cathartics and enemas, and although these seem like mundane treatments, we've seen patients time and again who've been brought out of coma rather promptly by doing nothing else except going to the bedside and giving a series of enemas until the patient wakes up. What we usually use is saline. We give 1,000 cc enemas of saline to which half a gram of neomycin is added so that we leave a little residue of neomycin behind in the gut. And we just run it in, leave it there for about 10 or 15 minutes, run it back out again, and then repeat this again. We do it 4 or 5 times. The elevated blood ammonia level can be helped by giving neomycin, which kills the organisms that help to break down the blood, and by the use of K-exalate, which is an ion exchange resin, which exchanges sodium for both potassium and ammonium. And of course, the danger of this is that you'll further contribute to the hypokalemia by giving K-exalate, so that you have to be sure that you give potassium chloride intravenously in fairly large doses when you give K-exalate by mouth or by enema. Now, as far as the bleeding varices are concerned, the Sengenstechen tube is perhaps the standard treatment for this. There's been a recrudescence of interest in the use of pitressin or pituitrin, which is capable of dropping the pressure in the portal system. It has a danger, I think, primarily in patients who have severe coronary disease because it tends to clamp the coronaries down some. But in most other patients, this is a useful drug and may help stem the bleeding. We found exchange transfusion very useful for bleeding varices because many patients with severe hepatic failure have a very poor tendency to form the blood clotting mechanisms. They don't clot blood well, and therefore, in part, their bleeding is due to low platelet counts and to low prothrombin time. An exchange transfusion with super fresh, warm walking donor blood done rapidly, and what we usually do is to exchange 15 units in about an hour and a half, has been capable of stopping bleeding in several of our patients with varices who were continuing to bleed with previous modalities of treatment. This sort of a new technique has been described since 1966, umbilical vein saphenous shunt, which by means of a pump is capable of directly doing an extracorporeal portacaval shunt under local anesthesia and will drop the pressure and will stop bleeding, and is a useful modality, quite simple to perform. The umbilical vein saphenous shunt consists of, under local anesthesia, exposing the umbilical vein just above the umbilicus, putting a catheter into it after dilating the vein up to accept the catheter. Then the blood from the portal system, which comes under high pressure, flows up into the umbilical vein, out the tubing, through a pump, and back into the saphenous vein again and into the vena cava. So it performs a portacaval shunt under local anesthesia extracorporeally, or you can drop the portal pressure at 200 millimeters of saline this way instantly, and when the portal pressure falls, the varices collapse and the bleeding stops. For the ascites and the hepatorenal syndrome, ethacrinic acid hydrodiurenaldactone are the old standbys to try to produce a diuresis. These should be used in conjunction with albumin. And if these modalities fail, as they do sometimes, a peritoneal saphenous shunt we found to be a very useful modality for treating this. It takes the acidic fluid out of the cavity, puts it back into the bloodstream, supplies the protein which was lost, and is a helpful thing to do. We've had about 8 patients come out of coma with the use of this treatment, and here's how it's done. You simply take a peritoneal dialysis tube, put it into the abdominal cavity, connect this to some other tubing, run it through a little pump, and pump it back into the saphenous vein. It's a ridiculously simple thing, and you just keep doing this for a day or two, and the patient's ascites, of course, disappears, and as it does, some of these people with the renal shutdown will open up again, presumably because the ascites contributes to the mechanical factors which are important to some extent in the hepatorenal syndrome.
Thank you, Dr. Hume. We switch organs now from the liver to the kidney, as Dr. Samuel R. Powers, Jr. provides some pointers in managing renal failure in the postoperative period.
I'd like to start out with a concept which I think would not be universally accepted, but I think it's important for us as surgeons, and this is that an abnormal internal environment is not the normal response to anything. We have been taught that following trauma, there are a series of changes which take place which produce an abnormal internal environment, and that we must either put up with these or in some cases accept without complaint the fact that our patients are retaining sodium and water and becoming edematous. I think this is not necessarily true. As a corollary of this, I would like to suggest to you that the way that an individual, and this is the kidneys or the individual as a whole, responds to trauma depends as much on the state of the individual at the time the trauma occurred as it does the severity of the trauma. And we have all learned that patients who are properly prepared for surgery with an adequate load of water and salt aboard, when the time comes for them to undergo a major surgical procedure, tolerate this much better than the ones who were treated by the old no water by mouth, no nothing by mouth, no fluids, no anything for 12 to 16 hours prior to surgery. The third and perhaps most important general principle I'd like to leave with you is that when organ failure occurs, it almost invariably goes through a period of what we call functional organ failure, which means that the cells are not actually damaged. And this is the time when we have the opportunity to reverse the process and restore normal function. If, however, we wait, the so-called functional failure will inevitably proceed to organic, actual, in the case of the kidney, tubular damage. And then the horse is out of the barn. Unfortunately, there's no very easy way of telling when this transition from functional failure to organic failure takes place. We know that it's a matter of hours rather than days, and therefore most of our efforts should be directed at trying to maintain the kidney function at normal rather than to let it slip and have to pull it back. Now, in order for renal failure to be normal, the first thing that we have to have is a metabolically active renal mass, but we also need to have a body that contains a proper volume and composition of fluid. Now, first as to volume, there is no method for measuring the amount of water which is in the functional extracellular space which is clinically useful. There is, however, a functional method of determining whether the amount of water aboard is that amount which is optimum for the patient's hemodynamic function. And this, of course, is the central venous pressure. Now, I'm aware of the fact that this, like all other things in medicine, is not the absolute ultimate answer, but as a clinical tool, it can be stated that if fluid is administered at such a rate and in such a volume that the central venous pressure is maintained roughly between 7 and 15 centimeters of water, then that patient has the correct volume aboard for him at that time. As you know, water can be sequestered in all kinds of places in the body. For example, there's no trick at all to put several liters into the gut. And if you're just weighing the patient or just following balance, you may not know that there are these 2 or 3 liters which, although in the patient in the sense that they're physically inside of him, are not in a space which is functionally in communication with the vascular bed. Well, if one has the proper volume, we mentioned that it also must be of the proper composition. And certainly of the things in the composition, the most important is the total osmolarity, and the thing which determines this the most, of course, is sodium ion. I think in this day and age, we need not accept values of 128 milliequivalents per liter in a patient as a normal value. Of course, it does not, and the sodium should be brought up or maintained at a normal value. What is frequently not appreciated quite as much is the effect of changes in the oncotic pressure, which is, of course, that part of the total osmotic pressure which is due to the plasma proteins. Well, I think one can say that in general, if we provide the kidney with an optimum volume as judged by central venous pressure, of proper composition as judged by sodium, and hopefully of protein concentration, usually the kidneys will work. What are the things which we are likely to see in the patient who develops acute renal failure? And these are just clinical observations. Well, these are people who have been hypotensive. In other words, the right volume has not been provided. They may have had abnormal globin pigment circulating, and the increased sympathetic tone is merely another indication of the fact that the hypotension has not been treated. Now, here's where this becomes important. Experimentally and clinically, these situations will not produce acute renal failure unless you add to it dehydration, hyponatremia. Now, if you do that and allow it to persist for several hours, then the chances of getting tubular necrosis is markedly increased. On the other hand, we have found, again clinically, that patients will very rarely develop renal failure if you can maintain a high rate of urine flow and if you can reverse the vasoconstriction. Now, this is usually easy to do if you restore blood volume, and this is functional volume, normal central venous pressure, normal blood pressure. If you administer enough balanced electrolyte solution so that you keep the serum sodium and things at a normal region, and if you get on this promptly. This means within 1 hour of the onset of oliguria, usually. Now, if, as occasionally happens, and this is more likely to happen in the patient who has sustained severe trauma, and which you have inherited the patient after this golden period of prophylaxis has passed, if they are dehydrated, and if they have circulating globin pigments, either myoglobin or hemoglobin, and the treatment has been delayed, you may still be able to return organ function to normal by the use of the agent we've used, mannitol. Ethacrynic acid is another one which is available and which is an excellent agent, and the only caution with ethacrynic acid is that it is, by golly, a diuretic, and don't ever forget it. It can put 3 or 4 liters of urine onto the floor in about an hour if you aren't careful. And in the patient who is in perhaps a little bit of a chancy state from their circulation, this might be dangerous. But in any case, the use of a diuretic, occasionally of a ganglionic blocking agent. I would like to suggest to you that apparently the response of the kidney depends as much, if not entirely, on the concentration of sodium in the distal tubule than any other single factor. And therefore, those things which will maintain the concentration of sodium in the distal tubule will be protective. Now, what are these things? Well, the first, of course, is just to keep up a good normal blood pressure so glomerular filtration rate stays up. That'll do it. The second thing is to provide a sodium load to the kidney. The use of large volumes of balanced electrolyte solution will maintain a high sodium concentration in the distal tubule where it will not be maintained in the absence of these solutions. The third thing you could do, if those don't work, is to give a osmotic diuretic like mannitol, which is a kind of a gentle, mild little thing which will tend to tease the sodium concentration up. And if that doesn't work, you can bring out the heavy artillery and give them ethacrynic acid. And in fact, there's a recent report which suggests that ethacrynic acid may be effective in patients where mannitol has failed to produce a diuresis following trauma.
Thank you, Dr. Powers. Our third speaker, Frank L.A. Grabodi, outlines for us now the prophylaxis and treatment of pulmonary insufficiency. Dr. Grabodi?
Well, in dealing with pulmonary problems, pre- and post-operatively, we're dealing with a very complex set of circumstances because the lungs are obviously intimately involved with the circulatory system, and a number of other factors which relate to pulmonary function are always at play. I think of all the various organs that one must deal with in pre- and post-operative care and in following them adequately, the lung requires more testing probably than any other organ. In other words, one has to have a laboratory or a group of people who understand the various parameters of testing pulmonary function. I'm not talking about pulmonary function tests. I'm talking about measuring PO2, PCO2, pH, and so forth on a continuing basis at all times, day and night, in order to understand what's happening, even moderately, in pulmonary function. To begin with, we might make a general statement. With the properly functioning cardiopulmonary system, effective gas exchange between the blood and ambient air is secured so that the arterial blood tensions are kept within normal limits. Mixed venous blood enters the pulmonary capillaries with oxygen partial pressures of 40 millimeters of mercury and carbon dioxide partial pressure of 46 millimeters of mercury, and comes out on the systemic side with raised oxygen partial pressures of 100 millimeters of mercury and dropped carbon dioxide partial pressures to 40 millimeters of mercury. When the functional reserve of the lung is reduced, there is a fall in arterial oxygen tension, PO2, a rise in the arterial carbon dioxide, PCO2, or both. It is at this stage that the respiratory failure is said to have begun. Respiratory insufficiency implies an inability of the lungs to exchange gases adequately to meet the needs of the body during effort or during increased demands. While respiratory insufficiency may be compensated for by reduced activity, increase of either stress or restriction can produce respiratory failure and death. For practical values, arterial PO2s below 50 millimeters or arterial PCO2s above 50 millimeters of mercury is called respiratory failure. In our own unit, we can variously estimate that approximately 50% of the cardiac patients we operate upon have depressed respiratory mechanics or function during the first 2 or 3 days. And I would also say that in general, post-operative patients, particularly those who have major surgical procedures, have an increased demand on their respiration because of pain or work or effort of breathing of approximately 20%. So that any respiratory deficiency the one starts with preoperatively, there is an additional burden postoperatively in various ways. Now, factors promoting respiratory insufficiency, pulmonary disease pre-existing accounts for approximately 70% of all the problems that we see. Smoking, we find in not only our series of patients, but other patients that we've heard about or read about, increases the possibility of pulmonary complications by approximately 3 times. 3 times as frequent in patients who smoke. We, in our open heart surgery program, try very desperately to stop people from smoking for at least 10 days before operation. And we try even more desperately to give them Sunday school lessons to stop completely. Obesity is, just by increasing the mass and making it more difficult for pulmonary expansion and work to take place, does increase the respiratory work, and therefore such patients are more liable to have problems postoperatively. The age affects patients not only because of changes in the lung, but changes in the circulatory system itself. Sex, the males are affected 2 to 3 times as frequently as females in having post-operative respiratory insufficiency problems. This is probably in the past has been related to smoking as much as anything else, but in some cases it's due to the type of work the man has been doing throughout his life. Pain, of course, restricts motion and causes atelectasis, and also this leads then to infection in some cases. Abdominal distension is well known to most of you as being a problem in pushing the diaphragm up and restricting ventilation. Anesthesia and surgery, of course, are well-known other causes of respiratory insufficiency. The specific goals, pre-operative treatment, we stop smoking. We have a chest physical therapy program organized with trained physical therapists who see each and every patient preoperatively, teach them breathing exercises, and in our instance, where one is dealing with open heart surgery patients, be sure that they know how to use a pressure respirator. In other words, the patient who post-operatively will require a pressure type of respirator had better learn about it preoperatively while he's more alert than to try to teach him after the operation is over. We, of course, treat purulent sputum, and any patients who have purulent sputum are treated with the proper antibiotics. And we try to convert this from one of thick sputum to at least mucoid sputum before performing an operation. Airway obstruction and the work of respiration, the bronchodilators, of course, aminophylline and isoproterenol, sometimes corticosteroids are used. But as I mentioned to you before, breathing exercises and the use of intermittent positive pressure respirators during the preoperative period, we feel, is very essential, so that all of our patients who have serious operations are brought into the hospital 4 or 5 or 6 days before the operation, and a regular regimen of teaching them and taking care of their pulmonary system is inaugurated. Cardiac failure, of course, in heart patients has to be treated energetically, and in a few patients who have irreversible and profound cardiac failure, it is necessary to do a preoperative tracheostomy and put a patient on a respirator. In these cases, it almost invariably is a volume-controlled respirator. And in some instances, this is the only way one can convert a patient from one who is surely going to die before an operation to one who can return to complete compensation. We've seen diuresis and alertness develop in these patients in a surprising degree when a tracheostomy has been done and proper volume control respiration has been inaugurated. The post-operative management in a cardiac patient, and this could be in any seriously ill patient, one who has had a prolonged operation or severe trauma, We usually leave the intratracheal tube in the patient for at least 48 hours if he requires it, or until his blood gas studies are approaching normal, his urinary output approaching normal, and this usually in the seriously ill cardiac patient will be within 48 hours. If at that time the situation is not stable, we move the tube to the nasal area, and we then will have a nasotracheal tube in for another perhaps 48 hours or even 3 or 4 days. If after that period of time, which is now 5 or 6 days, we're still having problems with ventilation and renal excretion, we will do a tracheostomy. But in our experience, the indications and the need to perform tracheostomies has decreased remarkably in the last 3 or 4 years. So that in our unit, at the present time, practically the only patients who end up with having tracheostomy are those who are in coma or have tremendous central nervous system depression or have serious heart failure and require the maximum amount of ventilation to sustain proper gas relationships, or patients who have other very serious chest or other abnormalities. The ordinary routine patient who comes off our operative list at the present time very, very rarely requires tracheostomy. The other routine management, we watch the intravenous intake, of course, and that is very carefully regulated. The patients are turned frequently. We have the tracheobronchial toilet, usually through a tube through the nose. In cases of secretion, we will irrigate the tracheobronchial tree, sometimes with antibiotics, but usually just with saline. Deep breathing and coughing, passive motion, and early ambulation. We also have the same physical therapists get busy on the patient as soon as they come back from the operating room. The same girls who have seen the patient preoperatively will come into the intensive care unit and start their respiratory physical therapy after the operation. I think probably the basic principle of therapy in managing these postoperative respiratory failures is to treat the potential reversible features while providing external support to correct the hypoxemia, the hypercarbia, and acute respiratory acidosis. And if the blood gas abnormalities can be corrected and the cardiopulmonary function maintained until the precipitating etiological factors are determined in the respiratory failure, then recovery is possible.
Thank you, Dr. Garbody. And now let me signal the end of this side of your program, Doctor. Side B, containing discussions of postoperative pancreatitis and pulmonary embolism, and a question and answer session, may be heard by just flipping over the cassette or 2 reels on your tape recorder. Continuing a program on organ failure following surgery, prophylaxis and treatment, this is Side B, Audio Digest Surgery, Volume 17, Number 7. Postoperative pancreatitis is identical to acute pancreatitis occurring at other times, except that all of the abdominal signs and symptoms are confused by the very recent postoperative state. The pancreatitis, therefore, becomes a great deal more difficult to recognize. Our next guest speaker, Daniel W. Elliott, describes now the diagnosis and treatment of this troublesome postoperative problem.
Postoperative pancreatitis may be heralded actually by any one of a number of signs and symptoms. Primarily, pancreatitis is heralded under these circumstances by back pain, by almost universally an increase in pulse rate, by the appearance of more distension and rigidity of the abdominal wall than you would have expected after the operation performed, and then also by signs of systemic distress, the ordinary clinical signs of respiratory distress or of falling urine output. I think any one of these signs calling your attention to difficulty indicates that, among other things to be done, a serum amylase should be determined. The determinations of amylase, lipase in the blood and in the urine as supportive of the diagnosis. They do not make the diagnosis for you. Perhaps the most sensitive of these determinations is actually the urine amylase. And this is because the diseased pancreas can spill huge quantities of amylase into the bloodstream, and this can be eliminated almost as rapidly by the kidneys if they are continuing to function, so that blood levels may never actually become elevated. But you can recognize the elevation because you measure urinary amylase in units per hour. If it's not measured as concentration in the bloodstream, but as units per hour, and when this is done, increases are readily apparent, and this, I think, is proving to be more reliable and more sensitive than serum determinations. Now, the frequency of postoperative pancreatitis is determined really in the literature by how often you measure serum amylase. A series of patients from the University of St. Louis, published by Bardenheyer and Wellman, they have made an effort to determine amylase on the first postoperative day in more than 500 out of their total of 840 biliary tract operations. A high serum amylase was discovered in almost 15% of their cases, yet not all of these patients had clinical signs of pancreatitis. The incidence, therefore, is determined, first of all, by being alert to the possibility. Secondly, how often you believe the clinical pancreatitis is present when the amylase is elevated. If it does mean pancreatitis, obviously a disaster has occurred. It did occur in 4% of the whole series, and of these, about a quarter died. So that postoperative pancreatitis does occur, at least after biliary tract surgery, sufficiently often so that those of you who are performing, say, 50 gallbladders a year may be expected to see a case of this twice a year. And if it occurs this often, it can be a problem to you. The operations which are commonly followed in our series by pancreatitis, the biliary tract operations, are by all odds the most frequent. They are also less likely to be as severe as the pancreatitis following other major intra-abdominal operations. The interesting thing about it is that with respect to 16 biliary tract operations complicated by mild pancreatitis and the 13 by severe pancreatitis, none of these had a simple gallbladder operation alone. They all were accompanied at least by a common duct procedure, a sphincterotomy, or at least by an operative cholangiogram. I think it is therefore true that those biliary tract operations accompanied by signs and symptoms indicating a need for more than simple gallbladder removal are more likely to be complicated by pancreatitis. The other more common operations, those dealing with dissections about the head of the pancreas and the duodenum in which a gastric resection has been performed, or in which the pancreas itself has been operated upon. I think probably a damage to the adjacent pancreas at splenectomy, and in the case of bowel resections, these were right colectomies for the most part. Damage or manipulation of the blood supply of the pancreas may have been responsible for the postoperative amylase elevation. If then one sees the signs of difficulty and obtains the serum amylase or a urinary amylase or both, and elevations are found, then you have the problem of the differential diagnosis, whether or not this elevation really means pancreatitis or does it mean some other intra-abdominal lesion which is also capable of elevating the serum amylase. Leaky anastomoses, such as a blown duodenal stump after gastrectomy, or perforated ulcer, compromised bowel produced by obstruction, volvulus or infarction, release amylase into the free peritoneal cavity from which direct venous absorption is sufficient to elevate the amylase. Here there is some value in having an early determination in that the amylases rise almost at once in acute pancreatitis, but more slowly when peritoneal absorption is involved. If one has an amylase which is normal in the first postoperative day, but an elevation later, then one can be more suspicious of peritoneal soilage rather than pancreatitis. It's readily easy to appreciate these mechanisms. With the common channel present, pancreatic juice is commonly found in the bile or in the gallbladder in the early postoperative period, and certainly perforations of the gallbladder or damage to the gallbladder may be responsible for peritoneal absorption, so also may be leaking suture lines or damage to the bowel below. The diagnostic paracentesis is the principal tool by which you can differentiate postoperative pancreatitis from other lesions requiring operation and which are dangerous to the patient. Here, the quantities of amylase in the peritoneal dialysate are not the important factor, but rather the nature of the fluid itself, whether or not it contains bile, whether it contains bacteria, and whether it has a foul odor. These are the three criteria of non-pancreatic lesions. In the presence of pancreatitis, it will have none of these: no bile, no foul odor, and no free bacteria. Other systemic changes associated with pancreatitis are also useful in diagnosis and, of course, must be borne in mind with respect to treatment. In particular, calcium will fall in the more severe cases, just as does in the idiopathic varieties of pancreatitis, usually requiring about 24 to 48 hours. This is accompanied by a fall, not a rise, in serum phosphorus. Serum lipids rise in a few cases. Cholesterols are often quite high. Blood sugars become diabetic transiently in the course of pancreatitis and usually return to normal with recovery. However, prothrombin times regularly fall, probably due to two influences. One of them, the antibiotics commonly used, and the other, some transitory change in liver function. Operation is necessary only rarely. This becomes necessary late in about 4 cases out of the 27, and it should be reserved for the late management. Pancreatic fistulas usually close spontaneously if recovery ensues. Treatment, for the most part, depends on management, just like a serious burn. Central venous pressure line is necessary in order to determine the right quantities of balanced saline. We believe that colloids should be used in a proportion at least of 1 part in 4 to balance saline. The urinary output and the gastric suction should be maintained. The contamination is a real threat and should be monitored by proper cultures. Vitamin K always administered because of the fall in prothrombin time and the serious threat from hemorrhage from suture lines in the GI tract. One may also need to look closely at the respiratory function and at the need for calcium and need for insulin. Finally, I'd like to encourage you that prolonged gastric suction is the most useful single tool. Maintaining it for a long enough period of time until sufficient recovery has ensued so the patient may be safely fed is probably the single most important thing that you can do. 80% of our patients did recover even though the attack was severe, and they did require quite long maintenance.
Thank you, Dr. Elliott. Our final speaker, Dr. Angus McLaughlin, turns to another organ involved postoperatively, the pulmonary circuit, in discussing pulmonary embolism. Here he is.
The most careful studies of the pulmonary arteries have shown that 60% of all patients coming to postmortem will have some evidence of thrombi, gross, perhaps smaller ones found only in careful dissection or on microscopic study. And it does seem that thrombi is something to which all people perhaps are subject, but it's a matter of degree that there's a very, very good fibrinolytic action in the lung clearing out these thrombi, and that the outcome is determined upon the equilibrium. That is, if they're coming up small enough in size or slowly enough, the lung handles them. If they're coming up rapidly enough and large enough, then they may reach a significant level. And it's well established that you must have a block of about 75%, or say 3 of 4 lobes of the lung, before the gross clinical picture of venous embolism to the lungs is reached. How are we going to make the diagnosis? Well, I think awareness would come at the very top of the list. Awareness of the possibility in anyone who is having post-operative trouble. Little bits of dyspnea, bouts of fall-off in blood pressure, the very rapid recovery from the embolus, I think, is one of the most characteristic things. X-rays of the lungs are notoriously inadequate. Only about 50% of pulmonary emboli will produce an infarct, and it's very difficult to separate this from pneumonia. Visualization of the leg veins and pulmonary arteries is accurate. Bob Freark has done a lot of old ladies with broken hips and has been able to show gross evidence of thrombosis in the leg veins in 1/3 of patients with fractures of the hip. The blood studies, we ran through a lot of these some years ago. This was a prospective study in patients who were likely to die. These tests were done twice a week and then compared with postmortem findings of another individual. And none of these were significant. That is, the false negatives and positives spelled it out. Now, the clinical test, swelling at the left ankle, was the only thing significant. If I make the point again that these were measured before death and then stored and compared with postmortem findings. More recently, and this is one we've not tested, an elevated LDH and a normal SGOT is believed to be significant, the SGOT being more commonly elevated in a cardiac infarction. This one, I think, has some credence. Scintillation has added a great deal to our studies, and that is scintillation studies will show that the I-131 on the albumin aggregate is not reaching part of the lung. Now, this is not itself a diagnosis certain of pulmonary embolism, but if the lung is clear, it is unlikely there's a significant embolus. And if you have in doubt of the wisdom of giving antibiotics and treating these things radically, the combination of scintillation studies and pulmonary arteriography will offer you the most assurance in going on to treatment. On prevention, the preoperative prevention, people have talked about the correction of associated diseases, all these being put right. Weight reduction in patients who are waiting admission for elective operations, I think, can be accomplished if you talk to them seriously enough. One I would like to stress of keeping activity and hydration maintained in the hours before operation. I would try to give any patient who has been off fluid since 10 p.m. the night before, who is not being operated on, say, first thing in the morning, but waiting on to the latter part of the morning or perhaps even afternoon, 1,000 or perhaps at a maximum 2,000 cc's of Ringer's lactate, in a hope that venous stagnation will be prevented during operation and the chance of an embolus or a thrombus starting in the operative part lessened. We found ourselves that elevation of the foot of the bed and the operating room table, the recovery room bed, and the foot of the bed is most effective. That on studying diclerant studies from the legs, this is more effective than vigorous walking in emptying the leg veins. This is the basis, I think, on which we must still base our treatment of pulmonary embolism, that most patients who survive the embolus will recover with good anticoagulation therapy, that this is still the basis of treatment of the patient who's had diagnosis or even strong suspicion of a pulmonary embolus. Of the anticoagulant therapy, I think heparin has distinct advantage over dicumarol. Harold Laufman has written almost an indictment of dicumarol in the last 2 years. Continuous intravenous would top the list. It seems impossible to keep the clotting times at a steady level. We tried this with a Harvard pump that would be very accurate in administering the heparin, but the clotting times, the Lee-White clotting times, still go up and down. I think this must be related to the activity of the thrombotic process in the legs, because in the few normals we did, it's much easier to maintain a person without a thrombus on a steady clotting time as compared to the other, that the amounts required in the first stage of the treatment seem higher than later on. And having been going for time, heparin given subcutaneously, and subcutaneously rather than the fat because of the lessened danger of a deep hematoma, are still very good. Dicumarol, if you're going to use it, I think that there are so many factors it doesn't control. It's probably closer to 4 or 5 days rather than 3 days before they take over. Now, what are you going to do beyond this? When do you ligate the inferior vena cava? And the best indications seem those of recurrent embolus with good anticoagulant therapy. If you want to change over, you can reverse the heparin or dicumarol effect by drugs, of course, or bleeding as from the prostatic bed or duodenal ulcer. Vena cava ligation is on, I think, more secure grounds than it was before with the many follow-up studies that have been done. The ligation is now perhaps done up below the renal veins, a little closer. It gives better collateral around. And having followed some of these by post-operative long-term venography, there's a tremendous collateral that builds up. I would still use a bit of narrow umbilical tape because of my belief that the collateral is so tremendous. And recently, Jude has fixed an umbrella arrangement that can be put up either from below or above and opened in the vein without the need to open the abdomen. This does seem well established, and on the belief that the subsequent leg disability is more related to the deep venous disease and the ligation. And patients who've had not much disease in the legs can be extremely good after this. In the septic thrombus that perhaps is most common from pelvic infections, it would be wise not only to tie the vena cava, but to do the ovarian veins transabdominally. Finally, coming down to pulmonary embolectomy, Trendelenburg had a go at this in 1908, as you probably know, but it's only since cardiac bypass has been developed that it's become more popular and more feasible. And enough of these are alive now to make careful consideration of the patient who doesn't die immediately, but who an hour or two later is still struggling, is not regaining the right heart bounce. This has been done, of course, by temporary bypass between the femoral artery and vein, but there's common belief that you're best to get them on total bypass and get a good job done, rather than doing some intermittent opening here, though there are new techniques of intermittent opening with sutures that try to do this without bypass. But on bypass, it's possible to clear the emboli out thoroughly, to massage the lung to get it out. Some people have actually driven saline backwards from the vein through the artery to wash emboli out in a retrograde manner. There have been some good results reported. Paneth of Brompton had 11 of 19 survivals with this method. As to determination as to when it should be done, I think that the scintillation study will give you your first hint that there has been an embolus. I think all people doing this work want to verify by cardiac catheterization that there actually is a pulmonary embolus. And then there's been interesting studies of the right venous pressures, Del Curcio, for instance, and Lloyd McLean supporting this, believing that if the cardiac catheter records pressures that continue above 22 millimeters of mercury, then you're getting on to the point of danger of right heart failure, that with the catheter in and the diagnosis established, if these pressures are not falling, these are the cases to go on.
Thank you, Dr. McLaughlin. Now let's ask each of our guest surgeons a couple of questions raised by their discussions. First, Dr. Hume, regarding liver failure, would you please elaborate on the hepatorenal syndrome?
The hepatorenal syndrome is simply a term that's applied to renal failure and oliguria or anuria, which occurs in patients in hepatic failure. And for a long time, nobody knew just what caused it. Nobody knows just what causes it now. But I think that we've learned a couple of things about it in the last year or two which have increased our knowledge of it. It is not a pathological change. It's simply a physiological change as a consequence of these toxins, whatever they are. Now, what are the toxins? And the answer is that nobody knows. They're metabolic products which are ordinarily detoxified by the liver, which are not detoxified by the failing liver, and which injure not only the kidney to produce the hepatorenal syndrome, but the heart to produce shock, and also they act on the liver itself to compound the liver injury. And this is why it's worthwhile to try to correct this condition in some patients with liver failure.
Another question, Dr. Hume. How useful is arginine in treating hepatic failure?
Well, we had a lot of experience with arginine in the past, and it's a tiny increment of benefit in patients with hepatic coma, but it's so much less good than a lot of other things that we don't really use it anymore.
Turning to renal failure, Dr. Powers, what test do you consider to be the most accurate in diagnosing renal failure?
That is a very good question. Once acute renal failure is established, I think there's little question that the best tests are those which measure the ability of the tubular mechanism to concentrate. Now, you can do this in many ways. You can measure urea levels. You can measure a variety of things. I think the simplest and most accurate, however, is the urine plasma osmolar ratio. You can get an osmolarity in about 2 minutes on an osmometer. You don't have to get a big sample. Just collect whatever urine you got and get a simultaneous blood sample with it. If this ratio is around 1, obviously the kidney is not doing very much to the filtrate, and this is tantamount to the diagnosis of renal failure. There's just one little catch in this. If you use agents, particularly such as ethacrynic acid, which have their good effect by precisely inhibiting tubular function, that's the way they work, then you may get urine which has a very low urine plasma osmolar ratio, and this doesn't mean the patient has tubular necrosis. It means that you've gotten the effect from the ethacrynic acid that you wanted. So, like all other tests, you have to use it in the clinical setting and the context. But I would certainly say that oliguria in the face of urine plasma osmolar ratio of less than 1.1 is diagnostic of tubular necrosis.
Do you believe that the central venous pressure is the best measurement of blood volume in normal renal failure?
No, I was very careful when I made that statement. I said in the clinical setting, in the patient who is in serious trouble and hypotensive, of all the methods that are available to you to estimate the patient's functional blood volume, central venous pressure is the best. Now, I suspect that, in fact, when combined with serial hematocrits, it may be better for measuring functional blood volume. I shouldn't really say this, but I suspect, as actually Jim Maloney first reported, it may be as good and perhaps even better than the blood volume determination. But I agree the central venous pressure has its greatest value in the situation where things are changing very rapidly, and the point, all of the dilution methods, and this is true of just a plain blood volume, require a steady state situation for a period of time for dilution to occur. And in the kind of patients we're talking about, they just aren't in any kind of a steady state for no time whatever. Just one other point is you've got to remember why you're giving all this fluid. You're giving it in order to restore organ function. And you've got a lovely organ, namely the kidney, which will tell you when you've restored organ function. So you use the central venous pressure as an indication to start. But as soon as you get a reasonable urine output, I don't care what the central venous pressure says, stop giving your fluids, because you've accomplished what you wanted to do, which is to get the kidneys going. And then if it falls off, you can give some more fluids.
Dr. Gerbode, 2 questions concerning your discussion of pulmonary insufficiency. First, how often do you usually change endotracheal tubes when they're left in post-operatively?
We usually leave the tube in that's in the mouth, the one that's used during the operation, for about 24 to 48 hours. We take the tube out depending on the gas analyses. In other words, when the PCO2 stays down with, let us say, the use of a bird respirator, which is a pressure respirator, with perhaps 40 or 50% oxygen, if the values are normal, then we'll take the tube out. This might occur that same evening, but most commonly in heart surgery, it's overnight, and in some instances, 2 days. If after 2 days, with the tube in through the mouth, with controlled respiration, the situation is still not right, we'll move it to the nose and change it every 2 days. But we seldom keep those tubes in for longer than, let us say, 6 or 7 days, and changing it about every 2 to 3 days.
Do you intermittently inflate the bags on the cuffed endotracheal tubes?
We don't intermittently inflate the bags on the tubes. We inflate the bag once to just enough pressure to shut off the air leak and leave it there. And we have a feeling that intermittent inflation of the bag produces more and more tension and more problems, and therefore we just inflate it once. Now, in some instances, of course, the tube fits so nicely that you don't need to inflate the bag very much. In our total series, I can't tell you how many tracheostomies we've done. We've done, as I say, in the past, many more than in the last year, but we have only 2 strictures on the whole group of patients. This represents something like between 2,000 and 3,000 open heart cases, and perhaps maybe 100 or 200 tracheostomies. And I think it's probably due to the fact that we don't fool with that pressure cuff too much.
Dr. Elliott, what is the overall value of cholangiograms in view of the reports of pancreatitis occurring after their use during gallbladder surgery?
I don't really have all the answers to that as to the overall value for cholangiogram. I can say, however, that cholangiograms can be done safely. And they can be done safely if you are using small tubes and you're most careful to apply pressure very gently and inject the dye slowly. There is really no rush about having the dye in, and there's no great rush about getting the film. This is not a vascular procedure, and the dye will fill the ducts, and it will remain there long enough to get the films in a leisurely manner. So that I think simply by restricting the amount of pressure used, you can do cholangiograms without developing pancreatitis. I personally believe that they are a valuable adjunct and should be performed certainly whenever there is any indication for common bile duct exploration, where we find intraoperative indications that were not recognized preoperatively. This is the place where we are most inclined to do them and where we believe they offer the greatest value.
Should anticholinergic drugs such as atropine be used in treating postoperative pancreatitis?
We do use atropine and believe that it does inhibit gastric secretions, and it does elevate the pH in the duodenum and therefore produce less stimulation to the pancreas. However, in the early postoperative period, it may also produce some serious side effects. It continues to elevate the pulse, particularly, and this may be a disadvantage. So that if a patient develops any marked toxic effects, particularly a marked flush, rapid pulse, or cerebral symptoms, we discontinue the anticholinergic, whether it's probanthine, atropine, or what, very quickly without hesitation. Now, you might ask, what's the objective evidence that atropine really does any good? In actual fact, there really is none. And yet we do use it because it has so few side effects and may possibly do some good.
Dr. McLaughlin, a question on pulmonary embolism. Is low molecular weight dextran of value in the prophylaxis of pulmonary embolism?
I think that there's real value in low molecular weight dextran. We have used it in a number of situations, but would still find heparin our most common agent. There are a number of tests that are used for the effectiveness of heparin beyond the Lee-White, or as we've been doing more recently, the Tygon clotting times, platelet adhesiveness, direct thromboplastin measurements, measures all across the broad level of the blood coagulation mechanism, which is so tremendously complex. But I think of the simple things that you can get done in a hurry. A direct measurement of the clotting time is still very efficient. I would certainly support the effectiveness of the low molecular weight dextran in the prevention and treatment of thromboembolism.
Do you anticoagulate patients with superficial thrombophlebitis?
Superficial venous thrombosis, I think, quite a different thing from deep. It usually comes as distended veins and does not lead to deep venous thrombosis. We would keep these up and about and would not anticoagulate them in the ordinary run. They usually finish up by local clearance. Now, I know that some people in advancing, very rarely, we've gone up to the top and ligated the long saphenous vein at its entrance, and some people have thought that it would be a good thing to get the acute thrombus out, and some people have gone on to doing stripping and excision of the vein at this time. I've never been that bold. There are series to suggest you can get rid of the immediate and the long-term problem. I do not think it likely that you'll get a pulmonary embolus from that level.
Thank you, gentlemen. And this concludes another edition of Audio Digest Surgery, produced and copyrighted by the Audio Digest Foundation, a nonprofit subsidiary of the California Medical Association.